A very good morning to everyone, as respected moderators, chairpersons, dignitaries, and delegates, and the participants of this ECG Masterclass 2026. We have an interesting cases and interesting lecture series today. I'll be starting with the first lecture. That is, it is basic of the ECG lead placement, standardization, QRS axis. A large section of the audience would be probably knowing a lot of this, but it's just a refresher course. And for other newer participants, it will be a knowledge session as well. So the objectives will be to understand how ECG lead placement is done, what are the implications of same, what is the importance of standardization. It's a very overlooked aspect of ECG, but it poses a lot of challenges if overlooked sometimes, and how to interpret the QRS axis, which is one of the important aspects of the ECG, which gives clues to diagnosis and sometimes helps in our interpretation. So ECG basically it's a fundamental diagnostic tool of cardiology. It was developed in by Willem in Eindhoven. It was initially done with a string galvanometer in 1903. You can see the machine how it was there, and it used to check the voltages by placing the limbs in a water can and then measuring the voltages by a galvanometer. That was the earliest ECG, to nowadays where we have come to very handheld as well as hospital based ECG systems that we are having. So basically a 12 lead ECG is the standard system that we use. It measures the electrical activity across the surface of the body. So we cannot directly measure the electrical activity on the heart non-invasively. So that's why we are using a ECG machine to check for the voltages and the differences over the surface of the body, and then get an idea what is the electrical activity happening inside the heart. So that is the basic function and how the ECG works. So what is a lead? We are discussing about lead placement and other things. So lead basically is a voltage between 2 points or poles as measured as a function of time. So we have 2 points. So basically it is the representation of the heart's electrical activity, and we are viewing it from a specific perspective. So sometimes it is interchangeably used with ECG electrodes that you would be seeing when we are placing over the limbs or over the chest, as you can see here. So the ECG electrodes are the single point where we are measuring the voltage. However, a lead basically means the difference between 2 points, and we are measuring the voltage difference. So we have 2 points, and one of them is usually a. So basically, we have 2 points. One of them is positive, the other one is negative, and when we measure the difference between the voltages of these 2 points, it is called a lead system. So we have three lead systems, basically two lead systems, but we measure it as a three lead system. One is the bipolar leads. As you can see in the frame, we have the lead 1, lead 2, and lead 3. Those are called the standard bipolar leads. And in the ECG, you can see the first three traces. Those are the lead 1 and lead 2 and lead 3 traces. Then we have augmented limb leads. Those are special kind of unipolar leads where we are getting to know, apart from the typical 1, 2, 3 leads, in a different perspective, we are getting to know the voltage. We'll come to each of them one by one, but you can see the middle portion of the ECG, or sometimes you can see in the lower portion of the left side of the ECG, AVR, AVL, and AVF. Those are the augmented limb leads. Why it is called augmented, that also we'll discuss. Then we have the precordial leads. Those are in simple terms known as chest leads. So we have 6 leads placed on the chest. Those are called precordial leads. Additionally, sometimes we can use posterior leads on the back side, where we can use 7, 8 leads, and sometimes we can use right-sided leads also if we want to get some additional information. So those are called precordial leads. So a standard ECG lead usually contains 12 leads, out of which 6 are the limb leads and 6 are the precordial leads. So what are the limb leads that we use? The electrodes are typically placed on right arm, which is generally denoted by color coding of red, on the left arm as yellow, and the left lower limb as green. Sometimes we can put it over the chest also when the patient is unambulatory, and when we are measuring in our routine OPD practice, we place over the limbs itself. So they are denoted as RA, LA, LL, and RL positions. So once we have placed the electrodes over these positions, then we get to the standard limb leads. So what are the standard limb leads? So the first one is the lead 1. So basically, lead 1 is from the right arm to the left arm, where left arm is the positive terminal and right arm is the negative terminal. Lead 2 is from right arm to the left leg, where right arm is the negative terminal and left leg is the positive terminal. And lead 3 is the third lead, where the left arm is the negative terminal and left leg is the positive terminal. So just to remember, you remember that left leg is both positives. Left arm is positive for lead 1 and negative for lead 3, and right arm is both negatives. It's not much to remember, but you can have an idea. It can help in interpretation also. So this system of limb leads, where 1, 2, 3 leads are there, it's called Einthoven's triangle. So basic principle is that when you have a circuit like this, the central point is usually a 0. That is called Wilson's central terminal. And the law states, Einthoven's law states that when you add the limb leads as per the polarity, it gives a 0 voltage. So basically, it comes out as 1 plus 3 equal to 2, because here the 1 is from negative to positive and 3 is from negative to positive. That's why instead of 1 plus 2 equal to 3, it is 1 plus 3 equal to 2. So the sum total is usually 0. So once we get this standard limb leads, we go to the next 3 sets of leads. Those are also limb leads. Those are called unipolar limb leads or augmented unipolar limb leads. So basically, once we have got these 3 directions of checking the voltage of the heart, we want to get to know other 3 direction also, that is in the frontal plane. So here what we use, the central point, as we told, that is 0, that we take as a 0, that is called a Goldberger central terminal, the central part of the body. So then we connect, so then we check the voltages from each of these limbs, one from the left arm, and the negative terminal usually is collected by averaging the 2 limb leads that are connected to this terminal. So there is a lead 1 and lead 3. When we join this, there is a central terminal averaged here, and from there when we check the lead towards the left arm, it is called left arm augmented lead. So it increases the voltage by 50%. That's why it is called the augmented limb leads. So you can see this is basically the formula. Usually the AVL is calculated as lead 1 minus lead 3, because the polarity changes here. So lead 1 minus lead 3 by 2. Again, AVR is calculated as negative of lead 1 and lead 2 divided by 2, and AVF is again calculated as lead 2 and lead 3 divided by 2. That is the formula how we calculate. So in this way we get a hexaaxial system. So you see here that we have got 6 leads, standard limb leads as well as unipolar augmented leads. Once we get this system, basically we are seeing the frontal aspect of the body. So we have our body, and if we have a plane that cuts through the center of the body in the frontal plane, in that plane we can get the view of the heart. The heart is here like this, and we are able to see the heart from various directions, as is seen in this hexaaxial system. So we have got, you remember this, this is the degrees are basically a standard degrees which are denoted. So the lead 1 is basically terminated as termed as 0 degree, because it is like this. Then lead 2 comes to plus 60 degree. AVF, because it is towards the foot, it is plus 90 degree. Lead 3 is plus 120 degree. AVL is minus 130. When we go anti-clock from this, it is minus. And AVR is either plus 210 or you can tell minus 150 degree. Sorry. So when you remember this hexaaxial system, it is very easy to interpret, to get to know what is the axis, if there is an axis deviation or not, which will come to the next. And once we see this, we record the voltages in the ECG. We get to see this kind of traces, the QRS axis. So usually the ventricular activation takes place first across the septum from left to right, then through the ventricle from basal part to apical part. That's why in different views we get this kind of deflections. In lead 1, because it is towards 0 degree here, the predominant axis is positive. The primary axis of the heart, it is basically across the lead 2 in normal hearts. So you get mostly a positive QRS in lead 2. Lead 3, sometimes you can get a biphasic one. And lead AVR is usually negative, because the heart's axis is usually away from it. So that's why you get this kind of deflections in the ECG. And you can then picturize what is the axis of the heart. Now coming to the precordial leads. So precordial leads are basically you are seeing the body across a transverse plane. So you have the body like this. The unipolar limb systems you are seeing in a frontal plane. Now you are cutting across the heart, and you can see here, sorry, that we have got 6 leads. So V1, V2, V3, V4, V5 and V6, and we are seeing the heart across the cross sections, and the central terminal is 0, and we can view the heart's electrical positions in all these different directions. So how are these leads placed? So basically V1 and V2, we place it in the fourth intercostal space. So it is easy to find out in a physical body itself. When you come palpating from the sternum and you feel a ridge here, that is called the sternal manubrium sterni, where it joins the body of the sternum, the sternal angle. From there, if you count the ribs, that is basically the second rib space. You come down gradually down, and you reach the fourth intercostal space. On the right parasternal area, you place the lead V1. On the left parasternal area, you place the lead V3. Then V4, you go one space below, that is the fifth intercostal space, and in the mid clavicular line. So that is the V4. And the middle point of V2 and V3 is V2 and V4 is V3. Next, you place the V5, that is across the anterior axillary line, the axilla's anterior margin in the fifth intercostal space. And the last one is across the mid-axillary line. So it will be somewhere here in the fifth intercostal space. You can further go back in the posterior axillary line and the interscapular line as V7, V8. And you can also place another electrode in the right side of V1, just opposite to V3 on the left side. That is called a V3R. So right-sided leads also you can get like that if you want some additional information. So this is the way you place the precordial leads. So once you have placed all the 12 leads, then you get this kind of system where you have a frontal plane where you are seeing the axis of the heart in a frontal axis, and a transverse plane where we are viewing a heart across the transverse axis of the heart. So this is the way you get to see the heart and find its electrical activities. So how can we know which is inferior lead, which is superior lead? So as we see the lead 3, AVF and lead 2, we are viewing the heart from below. So that is why those are inferior leads. Then lead V1 and V2, we are basically just across, the septum is like this, and we are seeing the heart from across where the septum is in a en-face view. So that is called the septal leads. Then we have leads V3 and V4 where we are seeing the anterior aspect of the heart. So most of the anterior wall MI and all you will find from V1 to V3, V4, they've got ST elevations. So that is the anterior leads. And the lateral most leads we are seeing, that is lead V5, V6 and 1 and AVL. So you are seeing the lateral side. AVL basically is a lead which is away from the heart. In normal axes, it is usually a negative axis.
Dr. Usnish, you just go back to the previous slide. Yes. So this slide is very important. I want all of you to capture this in your mind, the spatial relationship of the heart to the intervenous triangle, right? So what is the standard format of taking the ECGs? 3 lead, 6 lead, 12 lead, sir? 12 lead, louder sir. 12 lead, very nice sir. So yes, it is a 12 lead format. In the 12 leads, how much unipolar leads are there and how much bipolar leads are there? How much augmented unipolar?
3 unipolar, 3 bipolar.
3 bipolar. Louder, sir.
3 bipolar.
You are correct.
3 augmented.
3 augmented
And 6
unipolar leads. So what are the 6 unipolar leads? Limb leads are chest leads. Loud.
chest leads.
Chest lead. Good. So these are the basics. So we are starting with these basics. Yes, go ahead. Yusuf.
So what is the importance to know about these leads? Sometimes we can especially the technicians or paramedical staff when they are taking, even the doctors when they are taking in a hurry, we can misplace the leads. So that can lead to a misdiagnosis because a lot of conditions can represent similar kind of ECG. So you see this ECG, here you find it may look like a normal ECG, but you see in lead 1 and AVL, the P wave is negative, the QRS is also negative, T wave is also negative, both in lead 1 and AVL. And in AVR, it is positive. It is seen in a normal patient who had no history and all. So this is basically a right arm and left arm lead reversal. So sometimes you can mistakenly misdiagnose that the situs inversus dextrocardia or something like that. But that is the first step. The lead should be properly placed. That is the importance of the leads. Now coming to standardization, the next step. So this is often an overlooked aspect. We just go and start reading the ECG. But one thing you should identify whether it is standardized properly or not. So basically the ECG has got two axes, the y-axis and the x-axis. The y-axis calculates the voltage, that is in millivolt, and that is usually in standard 12 lead ECG. It is standardized as 1 millivolt producing a 10 millimeter deflection, so 10 small squares. And in the x-axis, it's basically the speed of the ECG, that is usually 25 millimeter per second, which we can increase or decrease as well. So once we calculate it accordingly, we have this kind of a graph where you have a large square which contains 5 squares, small squares on y-axis and 5 on the x-axis. So usually what happens, the 5 small squares usually represent 0.5 millivolt and 10 small square represent 1 millivolt. And across the left axis, when the speed is 25 millimeter per second, the 5 squares or one big square, it is 200 milliseconds and one small square is 40 milliseconds. So this is also important because on the x-axis you are usually calculating the rate, and the y-axis you are seeing the voltage, so you are seeing for any ventricular hypertrophy, chamber hypertrophy or not. So you see this ECG. Here you will see in every ECG there is a standardization. If it is taken properly, it has a standardization first before the traces start. So this 1 millivolt is basically standardized, that is equal to 10 small squares. And this side it will be 5 small squares equal to 200 milliseconds. Once you have confirmed this, then only proceed to read the ECG. So you see here, at first glance, this ECG, it may look like there is a left ventricular hypertrophy. There is a large QRS in V5, V6 and large S in V1, V2. But again, you see carefully, the standardization is not sorry. So you see this one standardization should have been a one large square, two small large square, that is 10 small squares, but here it is more. So any kind of this standardization is not correct. So your interpretation of LVH would be improper here. After standardization, next we proceed to axis. So what is QRS axis? So basically when we are checking the heart on the frontal plane, as you saw that hexaaxial system, that should always be sticking in your mind, which all leads or which all angles. You can tell what is the normal axis of the heart, or the heart has got some abnormal axis or not. Basically the QRS axis is more important, but we can also tell about P axis. We'll discuss mostly about the QRS axis. So it represents the average direction of the electrical activity during ventricular depolarization. It takes all the vectors and averages it's out. It is usually in the frontal plane, and reporting uses this hexaaxial system. So there is a 360-degree angle and a circle, and you can tell that. So it provides insights into a lot of diagnosis like chamber hypertrophy, sometimes in myocardial infarction, conduction system disturbances, some congenital heart disease and some arrhythmias as well. So the normal hexaxial system has got this 0 degree, 90 degree. Normal axis is usually considered minus 32 plus 90 degree. In children, it may extend up to 120 degree, more of a right side. Anything more than 90 to 180 is called right axis deviation. Minus 30 to minus 90 is called left axis deviation. And this minus 90 to plus 180 is called extreme axis or northwest axis. So determination of axis, we usually use the ECG itself. So we can see each of the leads. We need all the 6 leads, 6 limb leads to tell correctly which is the axis. So we can see the QRS, it is predominantly positive here. This QRS is predominantly negative, and this QRS is predominantly equiphasic. So we go and check what happens. So there are 2 ways to determine. One is the easy way, the quadrantic approach, which just gives you an idea whether the patient is having a normal axis, a left axis deviation, right axis deviation, and then you can go a little bit more accurate as the equiphasic approach. So the quadrantic approach basically identifies 2 perpendicular leads, that is lead 1 and AVF. If both are positive, then you tell it is the normal axis. If both are negative, then it is extreme axis, that is the northwest axis towards AVR. If one is positive and lead lead AVF is negative, then you have right axis deviation. Right axis deviation. And if you have lead 1 positive and lead AVF negative, then you have left axis deviation. You can see in the picture here. So basically, this is lead 1, this is lead AVF. Both are positive. That means the axis is somewhere in here. So it is a normal axis. If it is both are lead 1 is negative, lead 1 is positive and lead 2 lead AVF is negative, so axis is somewhere here. It can be sometimes normal axis also, but usually it can be left axis. And if lead 1 is negative, so here lead 1 will be negative and lead AVF will be positive, it's the right axis, and both are negative, it's the extreme axis. So you can just tell what is the axis based on this approach.
Yes, Dr. Usnish, what one of your ECGs, just hold on and ask them to answer it.
Yes, just 1 minute, I will go back. So these are just the examples I have given. So this is left axis deviation. You have negative AVF and positive lead 1. And this is a right axis deviation where you have negative lead 1 and positive AVF. So I will come to that. I have one ECG to show. I'll come to that once I discuss the second method. So more accurate method is called the equiphasic approach, where you can narrow down the axis to even 15 to 13 degrees. You can tell without seeing the interpretation of the ECG at the right side what is the axis. So again, you remember this hexaaxial system. It is more accurate, and usually it is followed like these steps. You find which is the most equiphasic axis in the QRS and find out which lead is 90-degree away from this equiphasic axis. And then if this lead is predominantly positive, so the direction of your QRS axis is along this lead. And if it is predominantly negative, the direction of the QRS axis is 180-degree away from the axis. So we'll see this example. So anyone can tell me here, first glance, the quadratic approach, what is the axis? It's left axis deviation or right axis deviation or normal axis?
Louder.
So how you are telling left axis? Yes, so lead 1 is positive and lead 2 is negative. So mostly it can be a left axis. But can you tell exactly what is the axis? So that's where equiphasic approach comes. So you tell me which of these 6 leads is equiphasic. In equiphasic means both positive and negative are there, are almost equal. Is it lead 2 or lead AVR? You see that AVR looks more like equiphasic, right? So that is most equiphasic. So AVR is plus 210 degree. So 90 degree from AVR, that should be the lead. Either it can be 90 degree on one direction or the other direction. So lead 3 is 90 degree across the 210 degree of the AVR, right? So you see here AVR is this one, lead 3 is 90 degree. On the opposite side also we can have, but we don't have a lead. Let's consider first the lead 3. So lead 3 is 190 degree across. So lead 3 can be one possibility. But you see here what is lead 3 now? So it is not positive. Lead 3 is basically predominantly negative. That means the axis is 180 degree opposite to the lead 3. So the final axis is basically 180 degree opposite to lead 3. It is minus 60 degree. So that is false in this left axis deviation. So from the quadratic approach, you can tell whether it is left axis or right axis. And with this equiphasic approach, you can finally tell what is the actual axis. You can come down, narrow down to even minus 15 plus minus 15 to 30 degrees from the real axis. So tell me, what is this ECG? Is it a normal ECG or abnormal ECG?
Yes, sir. My name is Venuvetrayan, sir. I work as a consultant, intensivist in PSS Hospital, Mandavais.
Please comment on this ECG.
Yes, sir. In quadratic approach, we can consider lead 1 and AVF, both are negative.
To see,
AVF
most of the leads are negative here.
most of the leads are negative, but we are looking for axis. So I am taking only lead 1 and AVF.
Okay.
Both are negative. Here it is extreme axis.
So it is extreme axis. That means in the
VO.
northwest. Now come to the, anybody else can come to the equiphasic approach. So it's basically white QRS tachycardia. It's not a normal rhythm, but it's a white QRS tachycardia. Someone can tell in the equiphasic approach which is looks like the most equiphasic among these. So AVL is most equiphasic. AVL is basically which degree? Hex minus 30. So AVL is minus 30. So like this. So which is 90 degree across minus 30. It can be either plus 60 or minus 120. So plus 60 is usually the lead 2. So you go back and see lead 2. What is lead 2? Negative. So it should be opposite, 180 degree opposite to lead 2. So then it is minus 120 degree. Usually we find out that it is basically minus 150 degree. So yeah, so lead AVR is 150 degree, but you see here it's not working. So AVL is clearly equiphasic. So the axis should be at least 90 degree from that. So it is basically 120 degree. It's in the northwest axis. There can be some deviation, but usually we can get 15 to 30 degrees close to the axis. So sometimes we cannot determine the axis. So here you see all the leads are equiphasic. So we cannot tell what is the axis. It's called indeterminate axis, usually seen in COPD and pulmonary disease patients. Sometimes you can have that, but very occasionally. So finally, summarizing my talk, so accurate placement of ECG leads and standardization are basic essential before interpreting an ECG. Often they are prerequisites because if you don't do it properly, it can give a misinterpretation or a misdiagnosis. And quick identification of QRS axis gives clue about a lot of conditions. So left axis deviation can be due to most commonly left anterior fascicular block, sometimes left ventricular hypertrophy, left bundle branch block. In case of inferior wall MI, right axis deviation can be due to RV hypertrophy, then the posterior fascicular block and right bundle branch block. So a lot of diseases you can have an idea once you get a glance and get to know about the axis. Thank you.